of W.E. Upjohn Institute for Employment Research, Michael Horrigan. Chief Executive Officer of Superior Health Foundation, Megan Murphy. And to moderate the discussion, please welcome President and Chief Executive Officer of Community Foundation for Southeast Michigan, Nicole Sherard-Freeman.
Thank you, thank you. Sure the mic's good. Doesn't misplace itself. Thank you so much for joining us this afternoon. There are lots of other places that you could be right now, and you chose to be here, and we promise you we're going to make it worth your while. So thank you for joining us. I have the privilege of leading the Community Foundation for Southeast Michigan, which, as some of you may know, is Michigan's largest community foundation. It is among the 30 largest community foundations in the nation, one of the oldest, one of the most established. And for those of you who aren't familiar with community foundations, really our purpose is moderately simple. We take the generosity of donors and match it with the needs of community. And we do that by taking in resources from individuals, families, and private foundations, and public partnerships, and corporates, and we invest very wisely in ways that create a multiplier effect, and then we redeploy that capital into community. And so right now, with the Community Foundation, that means $1.4 billion in assets that we get to put to work for Southeast Michigan. We serve a 7-county footprint, so Wayne, Oakland, Macomb, Washtenaw, Monroe, St. Clair, and who would I leave out? Livingston. Livingston, yes. I try to do that without looking at any notes, and then inevitably someone from my team has to fill it in. We are really excited about leaning into 5 areas of focus across that footprint. So economic opportunity, youth and education, health equity, arts and culture, and public space and environment. And we don't just write checks. We bring people together. We bring people together for important conversations like the one that we will have today, and we take on problems that can only be solved with partnerships and through partnerships, which is exactly why we are here. But enough about us. I want to talk about our panelists. So, and Dr. Mona hates it when I do this. So Dr. Mona Hanna is a pediatrician, a public health leader, and I think it's fair to say, this is the part she hates, look at her face. One of the most consequential Michiganders of our time. She serves as the C.S. Mott Endowed Professor and Associate Dean for Public Health at Michigan State University's College of Human Medicine. She led the Pediatric Public Health Initiative in Flint. She helped expose the Flint water crisis and guided the recovery. Time magazine named her one of the most influential people in the world. USA Today named her Woman of the Century. She can't wait till I'm done with this. And in 2026, she was honored again on the Time 100 health list, this time for RX Kids. I know Dr. Mona, and many of you know Dr. Mona as somebody who doesn't wait for other people to solve problems. She solves them herself. Help me welcome Dr. Mona.
Thank you. Thank you. Thank you, thank you. Thank you, guys.
Michael Horrigan, and I'm going to call you Mike here on out, in the center is the president of the W.E. Upjohn Institute for Employment Research, which, as many of you know, is one of the most respected independent labor and economic policy research organizations in the country. And before joining Upjohn, Mike oversaw the nation's employment and unemployment and inflation measurement programs at the U.S. Bureau of Labor Statistics. What we love about having Mike on this stage is that he brings the rigor of being a career economist to questions that, quite frankly, too often get debated with opinions instead of data. And so Mike is here today with us to tell us what the data actually says. Help me welcome Mike.
Thank you.
And Megan Murphy, we are so happy to have you with us today. Megan Murphy is CEO of the Superior Health Foundation, where she leads, obviously, grant making and community-led solutions across Michigan's Upper Peninsula. And she has 2 decades of nonprofit and philanthropic experience focused on health. Megan has been the driving force behind bringing RX Kids to the UP, including the largest single geographic expansion of RX Kids in the program's history, which just happened this past March.
Yes.
Is that right? Megan knows what it means to build something in a place that has limited infrastructure and people who are very proud of figuring out things for themselves. So Megan's going to tell us why RX Kids is such a good fit in her part of the world. So help me welcome Megan. So as we get started, it's super important to know who's in the room. So can you, just by show of hands, who's here from government? All right. And what about nonprofits? Oh, yes. And philanthropy? Okay, all right. Anybody in the room been pregnant or know somebody who was? That's great. So that means you are the right audience for this conversation. RX Kids, and the reason that we lean into this work and the reason we're so excited about having Dr. Mona and Mike and Megan with us to have this conversation is that RX Kids is one of the rare programs, at least in my experience, that really cuts through the noise. It is not a partisan program. It is not a government handout program. It's not a pilot that worked in a lab somewhere, without any data tested anywhere, and then somebody just decided to scale it. Like, it's none of those things. It's actually rigorously evaluated. It is evidence-based, and it is community-driven. And it really just asks a simple question, right? Like, what would it mean if we helped to resource families, moms and babies, at a time that is really, among the most difficult and fragile times in a child's life? And, the answer, and we have the data to prove it, is that things just get better. Everything gets better. Health outcomes get better. Economics get better. Economic stability gets better. Workforce retention gets better. When you invest in a mom and a baby in those first months, you are investing in everything downstream. And we deeply support this work because it aligns with our values. We want to center families, and we want to center what is right in communities, particularly around health equity, which we believe means access to health and opportunity for everybody. We actually had Dr. Mona present recently to our legal financial network, and those are some of the most pragmatic, strong, clear thinkers. And nobody, it was super interesting. The reaction was nobody said anything about ideology, right? They were just like, this is just good policy, right? It just makes a lot of sense, and that's what we're here to talk about today. So a couple of things. First, I have to acknowledge that Mayor Mary Sheffield, I'm pretty sure, just slipped in to the side of the room over here. Thank you for joining us. And are there any other? I think there are other electeds in the room. In fact, I see the mayor of Inkster, Byron Nolan, at the table in the back.
And RX Kids community.
And RX Kids community. Mm-hmm. Fantastic. Welcome, Mayor Nolan.
Senator Chang.
I see Senator Stephanie Chang. Mm-hmm. I see City of Detroit Councilwoman Angela Whitfield Callaway. And are there any other electeds in the room? I'm not wearing my distance glasses, so any other electeds in the room that I've missed? I don't want to miss anybody. All right. Okay. That's fantastic. So to get us started, Dr. Mona, could we ask you to ground us in just the basics of how RX Kids works?
Yeah, so Nicole, thank you. Thank you for all of you for being here. Thank you for caring about our mamas and our babies. And we are actually in an RX Kids community. Mackinac Island is part of the RX Kids family. It launched when we launched last March, 5 counties in the easternmost part of the UP. Thanks to generous philanthropy, thanks to state funding. The eastern part of the UP is kind of the highest need part of the UP. It was really important for us to prove that we can do something like ARC's Kids in Flint, but we can also do it in some places like in rural Michigan that are also struggling with lots of challenges to health. So what is ARC's Kids? How does it work? So who's not heard of ARC's Kids? Okay, great, I love you all. So ARC's Kids is lovingly called a prescription, because ARC's is that prescription, a prescription for health, hope, and opportunity. And it really came out of the frustration as me as a medical provider, a pediatrician, I still have the great joy of taking care of kiddos, of being frustrated for decades as a pediatrician both in Detroit and Flint, of not being able to prescribe away poverty. Every day as a physician, I Band-Aid. I treat the consequences of poverty, be it developmental delay or prematurity or low birth weight or chronic diseases. And we know so much that when you grow up in hardship, but especially when you grow up in poor places, it impacts your entire future health and wealth and opportunity. For example, in Flint, we know that there's a 20-year difference in life expectancy between different parts of our county. And that is throughout our state that your geography predicts where you end up. So really kind of born out of that frustration of treating patients in poor places, holding newborns in my arms, wide-eyed, beautiful newborns, and knowing that their socioeconomic conditions predict their opportunity. That, we mentioned my stubbornness and kind of refusal to accept this outcome. Like, I was tired, I was frustrated, I was angry. Where's Renee? What do you call it? Productive outrage. And that's kind of what birthed this kind of idea that we don't have to be okay with our babies growing up in poverty. We are the richest country in the history of the world. Every other country does better. It turns out moms and babies, that's the time when families are struggling the most. There's no other time in the life course that families are more economically vulnerable. Income drops, we don't have paid leave, and nominally one of the only countries in the world without paid leave. Babies are expensive. Who's had a baby recently, right? It's an added $20,000 in your first year. When you add up childcare and diapers and diapers and diapers and wipes and healthcare, so it's a drop in income, a rise in expenses. And so families are poorest around the most consequential time in life. Like what happens in utero, what happens in those first few months of life sets you on your entire path. It is foundational. So ARC's Kids was really kind of built on global science, built on the massive success of the expanded child tax credit in 2021, which dropped child poverty to the lowest level, a proof point that child poverty is a policy choice, and with smart policies, we can fix this. It is laser focused on moms and babies in a place-based ways. So everybody in an ARC's Kids community, including here in Mackinac Island, gets $1,500 every pregnant mama in mid-pregnancy, after 16 weeks of pregnancy. And then once a baby's born, it's $500 a month, either for 6 months or 12 months, and it really depends on how much money we're able to raise for a community. So it's a tiny, tiny time-bound program to address the economic instability of that consequential window with the goal of improving health. This is a health program. It's led by a doctor at a medical school with the goal of improving health at a population level. So that's kind of what it is. It's run by MSU, go green. In partnership with U of M. Go blue. Go blue. Go blue. Okay. And it is administered by the international leader in cash transfers, a nonprofit called Give Directly. This is all they do, efficiently, safely, and they're the ones that do kind of all the hard work with enrollment verification. So that's an overview of what it is and how it's run.
Yeah, that is super helpful. You've had support from funders and from policymakers on both sides of the aisle, and now you've got attention from other states. Mm-hmm. So, like, what is the argument from their point of view that's actually moving people, right? Like, is it the health outcomes? Is it the economic outcomes? Is it something else? What's really moving people?
Well, it's mixed, but I mean, some really, really smart politicians said poverty elimination is a growth strategy, right? So, I think people are starting to see that. You need healthy babies, you need healthy children to have a healthy community, to have a healthy workforce. Mm-hmm. So kudos, thank you. So I think there's lots of different arguments that resonate with lots of different people. So, for some folks, it is the health improvements. In places like Flint and Detroit and Lake County and Clare County where we're at, there are significant health challenges, significant disparities that make it really hard for kids to be born healthy and to grow up healthy. For some places, it's the child welfare prevention. So we'll talk about some of the outcomes, but we are significantly reducing involvement in the very costly child welfare system. So that's a driver, especially for some other states. Like, we want to cut costs on child welfare. For some folks, this is an answer to the impossible cost of childcare. For some communities, this is helping with housing stability. We had a 90% drop in evictions. So people are coming into it from different angles, but I think the bipartisan support is really grounded in its evidence base, in its time-limited design. This is not a program that goes on forever. It's just about babies. And everybody loves babies, right? Everybody loves babies. And we've really kind of centered babies in the narrative of this work. And people have, but it's really hard to not be a supporter of babies.
Well, let's talk about the really hard not to be a supporter of babies piece of this. You've got the Detroit News op-ed that drops today, if it hasn't dropped already. You've got the New York Times piece that dropped last night. Yep. But what argument are you making to Michiganders who are still skeptical?
Once again, the first and foremost argument is that this is a maternal infant health program, and it is working. It is working at scale. For so long, we have been kind of dancing around the edges. We have been band-aiding. And here's an intervention with, by and large, bipartisan support that is improving outcomes in many domains. There are a lot of polycrises that our families in this state are facing, from housing affordability, from childcare, to maternal infant health outcomes, to population stability. And here is one simple intervention at scale that is literally solving all those problems.
Mm-hmm. So, Dr. Mona, you've given us the vision and the values behind the program. We are in a room that is also full of policy people, and we've got some business leaders in the room. And we know the question for them is show us the numbers. And so, Mike, that's where you come in. We know that the Upjohn Institute has been evaluating RX Kids since its launch in Flint. And we know that the independent and rigorous research around this program is one of the things that really sets it apart. So, Mike, I wonder if you might tell us what the rigorous independent research actually shows, and tell us, too, what surprised you.
So I'm going to use the word affirming as opposed to surprising, because some of the results they're consistent with other studies that we've done, which is the jobs effect, for example. But before I get into it, I want to say thank you to Dr. Mona, first of all, for her leadership, but also I've been in Michigan for 7 years, and I think this is the first time I've worn a tie in 7 years. But she said you must wear red. So
you could have wore a red jacket or a red sock.
Yeah, I know.
I mean, you look good. You look good.
Thank you, but it took me 3 tries this morning, but I got it done. So you're asking.
But why are we wearing red? Like, why? Because this program is about love.
Right.
Fundamentally, this program, the logo is a heart, but it is about how we reimagine each other. Did you hear Cornell West? This is about love. This is about loving all babies, and that is why we wear red.
Yep. So, and thank you for the introduction in terms of the rigorous and the independent and the nonpartisan nature of our research. That is what we strive to do at the Upjohn Institute. And I want to give credit for the researchers that actually put these studies together. I'm representing them, but Brad Hirschbein, Tim Bartik, Irene Lindell were the sort of architects of the study that we did. And when I said the word affirming, part of this is the fact that, yes, this is a great program, great social policy goals, health outcomes, et cetera, but also at the heart of it, it's an income transfer. We're putting money into a community. And then the question is, what happens after we have that money going into the community? And Nicole, you actually used the word multiplier in talking about the work that you do. But multiplier is an economic concept that's really important, because one person's receipt of cash then becomes somebody else's spending money when that money is spent. And then that then multiplies down the line. So we have what is termed direct effects, that is the transfer of cash payments. as Dr. Mona described. But then when that spending occurs, and there's surveys that are done of the participants in terms of how they spent the money, what areas they spent it in. So for example, a large share is in retail trade. It's spending on babies, of course, but there's also the rent aspect that you mentioned, Dr. Mona. There's real estate. There's just a whole construction, for example. There's a whole host of areas that people spend the money in, and then that has an impact on the community. Even the people who are not directly affected by the program then benefit. And so with that multiplier effect, you get increases in personal income across the community. But in addition, because it increases the demand for the services of all the industries that are affected, and we're talking $10 million, sort of is the estimate in terms of the total amounts going into Flint each year. That's not a small amount of money. And with that, our models, basically we have two models that we use. Part of that is the rigor in the sense of don't want to just believe one model, you want to test the sensitivity of the results to alternative specifications. And so one model gives us about 100 jobs that are created. The other is more
in one city in 1 year.
Exactly.
In one city in 1 year, 100 jobs were created.
Yes, and the other model gives us a little bit closer to 200.
200 jobs.
And part of it is a technical difference in terms of where the money is spent and the assumptions that are made in the model. And trust me, I'm not going to bore you with the details. But just to give you a perspective, we're about to enter a decade of slower employment and population growth in this country and in Michigan. And if you take a look at the Michigan projections of employment, the average monthly change in employment over the next 10 years is going to be 208. And we're talking between 100 and 200 jobs in one community as a result of this each year. So this is a very powerful impact. So again, maybe pleasantly surprised would be the right word. But I find it affirming because we do a lot of evaluation studies. And one of the things that you get with programs where there is an injection of cash like this is you get a jobs effect. And so in some ways, I think it also raises the question of what are the kinds of cash programs could be effective.
So let's continue down that path of the ROI. And for those who are in the room who are business-minded, and I'd offer that to everybody, talk to us about the ROI for this. Like, make the case for it. Like, what does it cost a community not to invest in the first 1,000 days of a child's life?
Well, I think it's the other term that we often use is opportunity cost. It is the opportunity cost of not doing it. And I think one of the great things about the study, the findings that we have in this study, is the fact that the return on investment is greater than the cost of the program. So I mentioned that multiplier effect, and I was really focused on the jobs. But if you think then of the personal incomes that get created out of this, what that does is it basically expands the benefits of the program far greater than the cost of actually administering it. And the estimate that we have is a return on investment of 2.4, which is
every dollar that goes in
yes.
yields 2.4 in economic stimulus.
Exactly. And then another aspect, ROI can be often in terms of averages. We do a lot of our discussion of public policy in terms of what is the mean effect, what's the average effect. But the other way to look at it is the distributional impact. And so one of the models that we have does a very careful job of looking at how the incomes that are received by the community get distributed across basically the income distribution. And what we found is that it's very progressive. 40% of the personal income gain that we see in this program went to families that are in the lowest quintile of the family distribution of household income. That's pretty significant in terms of the reach that we want to have for the people that are probably in the most vulnerable positions, where we're getting that money to them as well.
So there's a little more to the ROI. So economic stimulus is what we're hearing. So families get this money. I love the word trickle up. So they get the dollars, they spend it quickly and locally in small businesses and grocery stores. In multiple surveys, consistent with other research on child allowances, the number one thing people spend their money on is baby supplies. And when you break it up, it's diapers. Like, by and large, it's diapers and like feeding supplies. And then it's food, rent, and utilities. That's what people are spending their money on. So once again, that's creating those downstream jobs at child care centers and grocery stores and big box stores and for landlords and what have you. But there's also cost savings. So for example, an article that was published yesterday by ARC's Kids in The Lancet, which was picked up by the New York Times, showed our population level improvements in birth outcomes. Improvements, we have less premature babies. We have less low birth weight babies. We have less babies being admitted to the neonatal ICU. All right, that's huge, huge. At a population, this is a big deal. These are stubborn, hard measures, and we are narrowing those disparities. So there is acute cost savings when a baby is not in the NICU. All right, being in a neonatal ICU is expensive, and not only for the health and detriment of that child and the family, but it is expensive to healthcare systems. So that is where we are acutely saving money. We are also acutely saving money in child welfare. And a paper we had published a couple weeks ago in JAMA Pediatrics shows a 32% reduction in investigations of infants in the CPS system. Round of applause. That's amazing, guys. That's amazing. We are preventing involvement in the very costly CPS system. Peak age of involvement in the CPS system is the first year of life because of the economic vulnerability of that window, more than 2 to 4 times any other year. You take a baby out of their home when they are an infant, we as a society pay for them to be in foster care until they're 18. That's expensive and also detrimental to that child and family. We are preventing involvement in the CPS system. So we are also showing short-term cost savings, which also is more than the cost of the program. So there's cost savings and there's economic stimulus that more than pay for the upfront investment.
Yeah, you both covered a lot. So Flint was the pilot, Michigan is scaling it, other states are watching. Talk a little bit, Mike, about what policymakers in other places need to get right if they are thinking about replicating this program.
Well, I think one of the things that we really need to consider is replicating the studies, is doing it in other areas. So this is a very important study, and it's showing very positive results. I think data-driven guidance to inform policy is a key ingredient of good policy making. And so if we have something in Flint, but then we also have some in rural counties, if we have some in Kalamazoo, we have very different communities that we're putting this program in, with very different sort of employment kinds of outcomes, industry mixes, different levels of wealth, et cetera, et cetera. So I think what we really want to show is this program is working wherever it goes.
Yeah.
Now, the 2.4 may be 2.8 somewhere else, it may be 1.9 somewhere else. But that's what you want to find out. I'm confident, just based on what we saw in Flint, that we are going to have the central finding that we had in Flint appear elsewhere, which is a return on investment. And I take the points that you make about the cost savings. That's another element that you can measure. These are things that I think are going to show through in all the communities. And it may be a more powerful impact in a community that has, say, a lower poverty rate, for example, in terms of how the personal incomes go. But you may have more progressive kinds of impacts in those same communities that have very high poverty rates.
Sure.
So I think data-driven guidance, so that you're saying to policymakers, don't just believe one study, but see how these studies have basically a lot of consistency across all the different communities in which RX Kids is.
And so let's follow that point and let's take it to on the ground discussion of what's happening in the UP. So we've got the program, we've got the proof, and now Megan, we're gonna turn to you to talk about what you've actually found as you've deployed the program on the ground. And let's be clear, the Upper Peninsula is very, very, very different than Southeast Michigan or the rest of the state, right?
Yeah.
Like we're talking about, you've got 15 counties.
Yep.
You've got vast distances. You've got not a lot of infrastructure. You've got, quite frankly, rugged individualists who feel very strongly about managing what they manage on their own. Let's talk about what's happening in the UP. You had the largest expansion in March. How does this program, Megan, even fit with your identity of how you see yourselves?
Yeah, so this was the largest geographic expansion, and it's also the most rural. And the UP is really defined by distance, weather, and that rugged independence, rugged individualism. And the people who live there choose to be there, and they have a shared sense of identity. That's why when you're in the UP, you see the UP on everything. You see 906 everything. You see everybody talking about Upers in every other sentence because we all feel very strongly about that identity. And that comes with a bit of a dislike of bureaucracy. It comes with some skepticism about rules that were not created with or for us necessarily. So RX Kids reflects a lot of our values in the Upper Peninsula because it cuts the bureaucracy, it cuts the red tape. It doesn't waste money on overhead, which isn't necessarily a waste, but there is very low overhead with this program. And it preserves that family's independence and their ability to make decisions for themselves. And it's also time limited, it is dollar limited, it's not an open-ended program, it's targeted support at a very specific moment in somebody's life. And that's, I think, a reason why we have that bipartisan support in the Upper Peninsula with particularly Senator John DeMoose and Ed McBroom. Senator McBroom actually said, you know, during the March expansion that if you're either not having a baby or you are, you're either having a baby or you're not. Like, there is no gaming the system. You're pregnant or you're not, right? So, you know, it's a far more efficient model because of that. That is the restriction, that and place, so where you are living at the time. But it's also an investment in placemaking and infrastructure. It's an economic and family driver. And that's something that's really been long overdue as an investment in the Upper Peninsula.
Yeah. Yeah. You've got tribal communities, you've got limited birthing hospitals. I mean, what does it mean from a real practical sense? And you know, I want to get these communities right. Like, what does it mean for a family in Gogebic?
Oh, good. Very well.
Hear that?
That's where you're from, right?
That's where I'm from, yes.
Or Ontonagon.
Yes, thank you.
Did I get that right?
Excellent pronunciation.
Okay.
Yes, thank you.
Right.
We hear all kinds of things, so I really appreciate that. But the UP is 1/3 the landmass of the entire state, and it covers over 16,000 square miles. So it is a huge piece of real estate. And it takes 6 hours to drive from one end to the other. But we only have 6 birthing hospitals right now. If you're pregnant in Ontonagon County, you cannot even have an emergency birth nearby because they closed the hospital in 2024. And if you are in Gogebic County, they just closed their birthing unit. And these are all economic considerations that go into why this has to happen or not. But a lot of women now have to deliver their babies in Wisconsin. I happen to be delivered in Wisconsin, even though I'm from Ironwood, because the birthing unit was under construction when I was born. And I'm still a Youper because it still counts if you had to do it by default.
But we have to put our marketing materials in hospitals in Wisconsin.
Exactly.
Where mamas are going to prenatal care.
Exactly. But you know, this is all defined by distance once again, and you add in the cost of gas, you add in the time it takes to get somewhere where you're going to do something you want to do, let alone something you absolutely have to do. And it takes a significant financial toll. It's lost time working, but it's also lost dollars that you might need for something else that's essential to your family and to your baby, like food and rent and diapers. So for families in any of these counties, I think RX Kids is a real lifeline. It is, you know, putting dollars into the hands of those families so they can make that travel, they can make that happen. They can stay overnight someplace if they need to, if they're in labor, but they're not quite ready to go to the hospital, or, you know, if they're getting close, or they can't, you know, travel long distances later on in their pregnancy. And because the program's universal, it also reaches our tribal communities, which we're very, very happy about. That is a big priority of Superior Health Foundation, as well as working with our tribal communities. And you know, we see that significant improvement in health and well-being across the board with moms that are being part of this program. So it's just been really an incredible thing for the Upper Peninsula. Again, a really wonderful investment in our people.
Yeah. So we know that Superior Health Foundation serves as the regional fiduciary in the UP for RX Kids. If there are foundations in the room that are thinking about that regional fiduciary role, like what should they think about before they say yes?
Yeah, so we watched RX Kids for quite a while. I was at the Michigan Health Endowment Fund when the program launched in Flint, and then took this position shortly before it launched in the Eastern Upper Peninsula. And we jumped at the opportunity when we had it to become a philanthropic partner. And since then, we have become the regional fiduciary for the entire Upper Peninsula, and we're working with primarily UP-based foundations to raise the private match for those public dollars, with the goal of sustaining this program for at least 3 years, hopefully a lot longer than that. But if you are thinking about this, you know, before you say yes, you do need to know what you're saying yes to, right? And so for us, it's a fundraising commitment. It is a coordination role. It is also a statement of organizational values, a very clear statement about what we stand for. And for us, the alignment was really clear. It is fundamentally about health. It is about healthy moms, healthy babies, healthy communities. And that is the mission of Superior Health Foundation, is to work to improve health in all of our communities. But it does take a lot of work too. We have been bringing together foundations across the Upper Peninsula for a while now. So we have had, we started building the relationships with them already, but they all have different sizes and different capacities and different willingness to, kind of go outside of what they would traditionally see as their scope in the counties that they specifically focus in. But they have really come together in kind of a, all ships rise when we're raising the tide across the Upper Peninsula. And we've had support from Copper Shores Community Health Foundation, Keweenaw Community Health Foundation, which actually gave us their largest gift through their unrestricted funds that they've ever made, wow. Which is so cool. $50,000, which is a huge amount of money for them. Yeah, we're really proud to be working with them. West End Health Foundation, Aspirus Health, Marquette County Community Foundation, Dickinson County Hospital Foundation, Dickinson Community Foundation, and the Sioux Tribe is another partner in funding this program. And then we've had some great statewide investment through the Michigan Health Endowment Fund, Blue Cross Blue Shield of Michigan Foundation, and then 2 national funders actually helped to launch that UP program, the Eastern UP program, the Bezos Foundation and the Perigee Fund. So we've gotten some even broader national attention with this, but because it's a universal program, it really makes that case making a lot easier. You're not debating on who should and who shouldn't be, part of the program. It's a lot easier for funders to say, yes, we want to do this for our community. And you're asking them to invest basically in every single mom and baby that is being born there. So, and I do have better numbers than this even up on our screen, because we pulled them yesterday. That's from April, but we have had over $3 million in cash prescribed now in the Upper Peninsula. Yes. Over 1,200 families enrolled and 727 babies born. So yeah, really proud of that.
Wow. That's amazing. I did thank you for that. I did a shout out earlier in our programming to the electeds in the room, and I'm pretty sure that Mayor Sheldon Neely of Flint just walked in, so I just want to pause for a second.
The original champion of ARCS kids in Flint. Thank you.
The original champion.
And right. Representative Neely right next to him.
Oh, Representative Neely. Yes. Thank you for joining us. So we could probably keep this conversation going for another hour. I mean, I'm sure you could. But one of the things that we love about this program is that it really gives us an opportunity to wrestle with some challenging questions. And so we want to open it up to you, Kaniqua Welch, who is our VP of Comms. If you've got, do you have question cards for us, Kaniqua? Fabulous. We've got about 10 minutes.
Nicole, while we're waiting, can I make one comment?
Absolutely.
So one of the things that we haven't dwelled on a lot, but is the fact that it's a universal program. And compare that to the efforts that are being made, like we're doing this in Kalamazoo, I'm sure it's being done elsewhere, on trying to make sure that people don't lose Medicaid come next January because of the reporting difficulties that people have. Maybe they report once and they thought they're done and they don't realize that they're not, or that they don't have access to a computer, or whatever the issue. Think about how much time and money and resources are going to go into trying to help people maintain their Medicaid. I think the universal aspect of this program is just brilliant, because it saves so much time and effort in terms of not having to decide who's above or below a threshold.
So I agree. It was designed not for poor people, but for poor places, to really address those geographic compounded diversities of living in a place that has challenges, or those zip code-based disparities that we talk about. That it's targeted universalism is kind of what it's called, where you do something for a whole place. That's also how we're able to get to a near 100% take-up rate. And that's just amazing. Like Wake has a 50% take-up rate. Home visiting programs have about a 20 to 30% take-up rate. So almost every baby mama that should be in this program is in this program. And that's because it's easy to understand. And I would also say another advantage of kind of treating an entire population is that we're telling families something different. Not that like you're not making it and here's a program because you're poor, there's something wrong with you. those things kind of really convey shame and stigma. But we're telling families, like, we see you and we hear you and we know how hard it is to have a child, and we are standing alongside you. We love you. So this is a program that is based on dignity and deservingness. And we see that play out in the data. Our mamas feel more loved, they feel more respected, they have more trust in institutions, more trust in government, more trust in healthcare. And I think that value is part of the design. And also the unconditionality, the no strings attached is conveying trust. And it's really hard to find a program these days that trusts women and trusts mamas and trusts poor people to make choices. But that is part of freedom and flexibility and independence. People don't want government to tell them what to do. They want to be able to best meet the needs of the family, and because they know what's best.
Yeah.
Especially the Upers.
Exactly.
Let's take a few questions from the audience. So, thank you. How can health systems partner with you?
Absolutely. This is called RX Kids on purpose, like the whole prescription thing, because this is a health intervention. We spend the most money in America than any other country in the world on healthcare. Can you believe it? We spend the most money than any other country in the world, and we have some of the worst health outcomes, especially in the maternal and infant health space. Some of the worst rates of maternal morbidity and infant mortality and terrible disparities, life expectancy. So we don't invest in health. We invest in healthcare, which is a reactive, sickness-based, profit-driven system. So one of our goals to kind of label this RX Kids and to have it really kind of be led by medicine and health is to shift some of those dollars that we spend on healthcare to prevention. Remember, we just heard an ounce of prevention is a pound of cure, right? So, and we are showing the cost savings. So a lot of health systems are funders, and we're grateful to that. We would love to get, we've been able to leverage TANF funding, which is the federal kind of cash assistance program, but we would love to be able to leverage CMS funding. And TANF funding is what, like $16 billion a year? Luke, help me. But Medicaid is like hundreds of billions of dollars a year. We are saving Medicaid money. Remember, every NICU prevention, all these things, we are saving money. We would love for that money to flow back into prevention. We're not there yet, but we keep asking.
That's great. That's great. Second question from the audience, and I can tell there are people in the audience who are thinking about implementation. So can you talk a little bit about whether there are just like key indicators, any checklist items that are supported by the research that indicate whether or not a community would be successful in launching the program?
Yeah, we had, so we received an investment in the state budget last year, and we had an open application process for communities to be part of RX Kids. And it was overwhelming. We had like 20 to 30 applications. Communities wanted to be part of RX Kids. And we couldn't select all because we didn't have enough state funding, but we had a selection advisory committee. Many of you were part of that selection advisory committee of statewide organizations that really kind of have a pulse on what's happening throughout the state. And communities were selected really based on need. Once again, I wish it was a program for every mama, every baby. We hear that every day. Everybody wants this program. But we made sure that we went to places with high need. Medicaid birth rates are a really great proxy for kind of economic instability in that window. Child poverty rates, county health rankings. There's a lot of measures that can really look at the need. The closing of birthing hospitals, the transportation. So there's a lot of things that help us assess need. So the community had to have need. The community had to have the match funds that were needed. So we haven't talked about funding. So this is a public-private partnership. When we started out in Flint in 2024, it was about 30% publicly funded, 70% privately funded. But we made a commitment to philanthropy, a promise to philanthropy, because your number one question is sustainability, that we would flip that ratio, that we would quickly show success and make this more of a publicly funded program. Right now, it is 80% state funded and 20% other funded, which is pretty amazing. So communities had to come in at that 20%. They had to have some match funding to be successful. And then the last kind of ingredient for success is that the community had to want it. They had to be a community champion. The city of Detroit raised their hand and said, we want this. Mayor Sheffield said, before she even was elected, said, I want this to be the very first thing. So we knew the community wanted, so we were able to kind of leverage those other pieces and make it happen. Other community champions across the state, the health department's the community champion in the Upper Peninsula. Cradle Kalamazoo in Kalamazoo, which is this amazing nonprofit committed to reducing infant mortality. So there had to be match funding, it had to be kind of a high-need community, and there had to be interest from that community.
Great. And this question is for any of you, and Megan, maybe more for you since you're on the ground with the program right now. Are there any ways that you're thinking about perpetuating the success of RX Kids into early childhood development?
That is a wonderful question. I mean, I would love to see on the ground in the Upper Peninsula that this program does continue on beyond 6 months for the families that have enrolled in it currently. I think, the longer term support that we can give to families as they enter into that early childhood phase would definitely make things easier for those parents. Childcare is expensive. It's very limited. There are very few options in the Upper Peninsula on where to take your kid while you're going to work or anything like that. And I think anything that can support parents that will help them, maintain their space in the workforce, but also give their children a healthy place to go and, learn when they're very young is something that this program could really help to bolster. So I'd love to see that.
Go ahead.
Can I give a data geek answer?
Yeah, please.
I think one of the things that would be absolutely wonderful is to have connected data systems that follow the kids through school, through life. Yeah. And that's, applause is great, it's hard to do. Yeah. It's really hard to do. So Kathy Zenda-Wilson is here from Pulse as part of the Upjohn Institute. And one of the things that Kathy has done is work with the city of Battle Creek. And they have, is it a welcome basket? Is that what they call it? Well, so it's to greet every mom and baby, but it also enrolls them in a data system that then follows them. We have in Kalamazoo a community data system where the birth records we received from the state through a research grant, we could then follow them into public schools, and the public school system has those records. The problem is some of these data sets disappear. The contractual basis by which you get the data ends at a terminal point, and then you have to reapply and it's not clear you're going to get it. What we need are sort of longitudinal data systems that follow from birth so that we can see what the outcome of Head Start is on adult outcomes.
That's right.
That's my data geek enthusiasm.
Yeah, and there are a couple data geeks in the room because I have questions about longitudinal studies.
But I think
Megan,
Dr. Mona was going to say something too.
I could keep talking forever. You can
Yeah, stay around for like the post-game show. So Megan, we're going to direct this one to you too. Are the prenatal pediatric visits being attended significantly more than you think they would have been otherwise? Do you have any data around that?
I personally don't, but RX Kids absolutely does. And I do know that compared to, pre-RX Kids, or control studies with other groups, that it has definitely increased prenatal visits. And we're really proud to see that because, once again, in the UP, it's hard to get to those visits depending on where you live. If you're in Marquette, not so bad. If you're even, 20 miles outside at K.I. Sawyer or in Gwynn, it's a lot more difficult. So
we had a paper published in JAMA Network Open just specifically about prenatal care utilization. And contrary to trends that were happening nationally, where there has been a decrease, and especially in first trimester prenatal care, after RX Kids started at a population level, and this is research in Flint where we've been the longest, more mamas went to first trimester care, which is before the program even started in anticipation of the program, because you have to prove verification that you are at least 16 weeks pregnant. So we had more first trimester prenatal care. We had more of something called adequate prenatal care, which looks at when you start prenatal care and how many visits you go. And we had less mamas with no prenatal care, folks who just come in and deliver. So there have been significant improvements in prenatal care utilization. This is not like a paternalistic program that's telling mamas, hey, go to your prenatal care, you have to go to your prenatal care. They're going. We even have decreased smoking at the population level in pregnancy. Not telling mamas stop smoking, but because of the decreased stress, because folks are going to prenatal care, getting to education, we're seeing these big outcomes in care utilization.
That is terrific. Terrific. Any impact on moms being able to extend their maternity leaves? Any data on that yet?
We don't have data on that, but anecdotally we hear that. So yesterday at a session, I think we heard from somebody that, and 50% of families go back to work. It was at 2 weeks or 4 weeks, so very early. 1 of the 2 weeks. 50% of families moms go back to work at 2 weeks. One of the reasons ARC's Kids started a couple years ago, I mentioned this earlier today. I was in clinic and there was a newborn that was coming in, a 5-pound baby, a premature baby coming in for their 4-day follow-up visit after being discharged from the hospital. The baby had to come in. We had to check the weight. We had to see how the baby was growing and feeding and doing. And it was a no-show appointment. The family didn't show. So my office staff finally got a hold of the mom and said, we need to see this baby. Why didn't you come in? Baby's 4 days old. And mom said, I had to go back to work. I had to go back to work. Okay, we are one of the only countries in the world that doesn't have paid leave. Us and a few island nations don't have paid leave. We abandon mothers and families, and we make them have these difficult choices to go back to work instead of going to a checkup or being there with a newborn. And then we ask other people to raise our babies. So we are hearing a lot from families that I can stay home a little longer. I can be present, I can parent. I remember we have an amazing mom in the UP. She's like, this is my 3rd kid. This is the first time my husband was able to take any day off after having a delivery. So the flexibility of the program gives families the freedom and choice to pay for childcare or to go back to work.
Yeah.
So a community is interested. What's roughly the timeline from deciding that you're interested to the point of you're enrolling your first family?
Yeah, so the beauty of the program is it was built for scale. Even when we launched it in Flint, it was never about Flint. It was about building something simple, super simple. We are just giving cash. We are not doing any complicated case management, wraparounds. We're just giving people cash. And that was by design. It's a simple program that was designed to be replicable. And that was always kind of our mantra in Flint, especially with Michigan State University, is that it's not about here, it's about sharing the awesomeness that we do with kids and communities, be it about pipe replacement or environmental justice or children's health. So it was always built for scale. So right now, we can, with funding at the table, and it doesn't matter where the funding comes, we can launch in a matter of months. You mentioned out of state, within a few months, we'll be launching in several states. We already have funding commitments in Ohio, in Oregon, in Mississippi, conversations in Washington, and Maryland, and Arkansas, and the list goes on. All kinds of states, red states, blue states, urban communities, rural communities are looking for plug-and-play solutions that are once again addressing the poly-crises that people are facing, from childcare to housing. Mississippi just declared a public health emergency for the highest rates of infant mortality. And they're looking at solutions, and they're looking at ARC's Kids to come in to help address these stubborn issues and transigent issues.
Yeah. So Dr. Mona, this sort of last question, and I have a question for all 3 of you, is you know what you had in mind when you and Luke talked about the design of this program early on. What has surprised you?
What has surprised me? Professor Schaefer, Dr. Luke said that this is the evidence-based policy of evidence-based policies. This is so duh, right? So people have been doing this across the world forever. I was born in the UK. I'm an immigrant. When I was born, I asked my mom, I didn't even realize it until I was deep into the weeds of ARC's Kids. I'm like, Mom, when I was born, did you get money? Did you get money, for me? And my mom literally shrugged her shoulders. She's like, yeah, of course we got money. It was the family allowance. We got a few pounds for you and for your older brother. And it was this recognition that, of course, a community, a society, a government takes care of their babies, right? So UNICEF, 76% of countries in the world do child allowances. They see it as social security. You take care of the old, you take care of the disabled, you take care of the young, because it's an investment in your nation. It's an investment in your community. And I think what has surprised me the most is kind of being able to reimagine with all of you how we take care of each other, and to think about how we can restore that really fragile social contract work. So that precious relationship that individuals have with institutions that has been so, corroded over time, and that we can do something so simple, and that it could not only improve health and eliminate poverty, but it could also restore trust. Like we're seeing restored trust in government. In Flint, of all places, we're seeing restored trust in government because of this simple, common sense intervention. So I think I'm surprised that we're seeing results so quickly. I'm surprised kind of really by the demand, but in some ways I'm not really surprised. Like this is expected, this is built on evidence, everything we've shared, even if we did no research, we would have expected.
Yeah, yeah. All right, lightning round question, guys. You've got 30 seconds or less.
Okay.
So your best answer. So we are at a conference about finding common ground. Mm-hmm. If you could ask every person in this room to do a thing, to think about a thing, do a thing before they leave the island, what would it be? Megan, start with you.
So I would say before you leave, ask yourself whether you're willing to put your name next to somebody from across the aisle for a project that's going to support your community. And think about the fact that RX Kids has bipartisan support in one of the most independent-minded regions of the state because it cuts bureaucracy, it respects families, and it delivers results. And then go home and make this possible where you live.
Beautiful. Mike?
There are so many different groups here, the nonprofits, the politicals, et cetera. But I would appeal to the business community to understand the business case for this and say this is a worthwhile investment.
Beautiful.
I'm going to repeat this. Poverty elimination is a growth strategy. It is.
I just have to say this, like we're at a conference talking about common ground, and this is proof, right? Like we're not talking about finding common ground as if it is some pie in the sky, by and by when we die thing. It is, we're doing it right now.
We can
right?
do hard things. We can absolutely
can
proof
do-
point. We
Sure.
can do hard things.
We can do hard things.
And
yeah.
it's not like
We don't
common
need more
ground.
conferences about doing hard things. We can just do the hard things.
And it's not like common ground, but it's common ground on the ground.
And it's common sense.
Common ground on the ground.
Yeah.
Common ground on the ground. So there is a QR code on the card on your table if you are interested in exploring RX Kids for your community. It's the same QR code that you see on the screen. Thank you again to the electeds, to Mayor Sheffield and Mayor Neely and Mayor Nolan and the others in the room, council representatives and state representatives, state senators. Thank you for
Funders,
taking time.
everybody.
Funders.
Funders,
Thank you for
partners.
taking time out to join us. We hope you found this a benefit, and go enjoy the rest of the conference.